for lack of a better word. Some of them aren't, but a lot of them are, particularly if they're new or if you have a patient with lots of secretions. So a patient with lots of secretions, we like to use the pink, and the reason is that it doesn't stick. So it will sort of contain secretions in a place, but it won't stick to the skin and the secretions. Things don't dry. If you have a nice clean trach, nice clean skin, then you can use the gauze. If you are using the gauze and you get lots of secretions, but they're dry, I would use normal saline to get the gauze wet so that when you pull away, you don't pull skin. Lots of different kinds of trachs Ms. Foss has here for you. These are the Shiley Flex. The nice thing about these, and it took us a while to figure it out, is that they're color coded. So you guys are all pretty young. Your eyes probably work really well. As you get older, that is not the case. The nice thing about these is that it has a little square. Have you guys looked at these?
No.
Okay.
They need to like explain the parts.
Awesome.
Of the trach and everything.
Okay. So, do we have one out already? Okay. We'll start with this one.
If you need something you don't see, let me know.
Sounds good.
So you need to check back here.
So this is a Portex. It has a pilot balloon that is usually inflated with fluid. And that's because this is a long-term home patient, usually a long-term vented patient who has a Portex. We don't usually put these in for short-term trachs. Also, they're used very often with kids because they have this little flexible extension. So it allows for a lot more movement. So they like to use this style of trach with kiddos because they move a lot and they aren't as cognizant of what's going on here. Obturator, it's like a stylet for your trach. If you're putting in a trach, in an emergency situation or in a regular situation, the obturator goes into the trach. Once you've got the trach in place, the obturator comes out, just like a stylet on an ET tube. This probably goes with this little red part here. This is the cap. So we use this when it's time to see if your patient can have their trach taken out. You would cap it. So in order to have a patient no longer need a trach, we usually downsize. So if they start with like an 8 or a 6, you would go down a step by 2. You can bridge with the Shiley Flex because they do have size 5s, size 7s, and a lot of them do, but usually we go 8 to 6, 6 to 4. Once they've got the smallest trach that they think they'll need, as long as the patient can manage their secretions, they'll go ahead and cap it. So once it's capped, it's no longer an appropriate airway. They're doing all the work from their upper airway. They have to remain capped at our facility 24 to 48 hours, be able to manage all their secretions, be able to ambulate if they're ambulating, and in order to get it removed. And that means in that 48 hours, this cap can never come off. If for any reason you have to remove it, the patient starts to struggle from a respiratory standpoint, they can't clear their secretions, anything like that, it's a no-go. Trach stays put and we try again later.
So you guys separate from, like when we take an ET tube out, we just do the trial and we take it out.
Yeah.
Trachs get slowly downsized. So it's from the usual, most people, adults have 8s. And so like she was saying, from 8 to 6 to 4, and then cap it, and then it's a process called decannulation. So when you hear that. So it's very different than ET tubes.
Yeah. Once they've been decannulated, they still have an open stoma. So the stoma gets covered, and then it will slowly heal. So that is all of the pieces except for the inner cannula. These Portex don't actually have an inner cannula, again, sort of because they're a home trach. That's one of the things about them, is that they don't have one. The Shiley, however, does. So this is a Shiley Flex. If you look at the phalange on this one, you can see a little colored dot. That's what I meant by color coded. So that colored dot matches the color on the package and the color on the box. So rather than having to try and see it, which is not always easy. If you can see the little color, you know what size they have. Let's see. So this is an XLT trach. XLT stands for extra long. It has a different style of inner cannula in that you have to twist. So this one goes in, and then you have to find kind of the right place, and it twists close. The flex pops in, and it has the base of the inner cannula on the flex is like a pinch. You pinch, and it slides right in. But this one you have to turn. Let's see. This pilot balloon, air, not water. The only one we really ever use for water is the Portex. Otherwise, it's air. You should check your pilot balloon every time you check your patient to make sure that it's full if it's supposed to be or flat if it's not. Just because they have a cuff trach doesn't mean that the cuff is always inflated. With the water, you would use either a 10 ml syringe, or you can empty a flush if you don't have one available. Once a shift, we pull the water back to make sure there's the appropriate amount of water in there, and then we document that. So that's something that you'll want to know if your patient has a Portex, is how much water they have in the cuff. The air is sort of more by feel. We measure pressure with the air cuffs, but not volume. Let's see. I think that's pretty much it on the different trachs. Questions about the trachs, their pieces?
You guys, we're gonna have those around for everybody to be able to look at, and I can put them right in the back too.
Yep.
Get to that point.
Okay. So trach care, we'll talk about the pieces of this first. This is called a trach collar. This would be used for the patient who is set up for a cool aerosol mist cam. Blue tubing connects, and then there's a water bag, and then up to the flow meter. Cool. So then trach, this is just regular gauze, trach ties, and that's pretty much it for what we've got on. Now, to do trach care, I like to have a clean specimen cup, 4 Q-tips, and gauze. And then the mix that we use in the cup, it varies from facility to facility. We do half hydrogen peroxide, half sterile water. So I put in my mix into my sterile cup, and then I use all 4 Q-tips, and I separate them by quadrants. So I never use the Q-tip in different quadrants. So my trach is 4 quadrants to me. That's how I think of it. Up, down, and I clean accordingly. I clean each of those quadrants. I start from the center and move out, and then down at the center and move out. So you never want to go over the same place with a dirty Q-tip, right? Because then you're taking whatever bacteria or whatever you picked up at the center, you want to move it away from the stoma, and then you don't want to bring it back. So you step down and clean, and then down and clean. Same thing going up. So we'll go center here. I usually will do just like a little twist to kind of get it underneath, and then come this way. And of course the gauze has to come out. So we'll take it out.
Some places also have trach kits. They're not used a lot anymore because they're very expensive, and it's just easier to get gauze and Q-tips. But these are around too, so if you see them, we'll have those out to see.
I think we keep those at the facility, but I've never used one and never
most people
seen one
don't.
used.
The biggest thing you need is something for the solution, Q-tips, and gauze.
Yeah, that pretty much covers us. So one of the other really important things that when you're doing trach care is that you talk to your patients as you're moving through the process. If my patient is awake and has a forward-thinking brain, I always ask permission. But also I kind of tell them exactly what I'm going to do as I'm doing it. So I always start out by saying, okay, we're going to go ahead and remove the gauze, and I pull it out. I, just out of habit, apologize a lot because I know it's uncomfortable. So as you learn to talk to your patients, you'll kind of get in a rhythm, but I pretty much say the same thing every time. And then I let them know we're going to go ahead and clean the skin. It should be cold and wet, but it shouldn't hurt. If it hurts, I kind of want to know, right? As I'm doing this though, you're also inspecting the skin and you're looking at the area. You're checking for anything that looks red or discolored, anything that looks like might be breakdown, any bleeding, anything like that. So I start at the center and get under the phalange and wipe away. And then I come down just a touch and wipe away, and then down again and wipe away. This is no longer any good to me. I throw it away and I take my next one. Same thing at the top. Start just under and wipe away, and then come up just above, wipe away and wipe away. And I'll do that in all 4 sections. So same thing this side, same thing that side. Once the area looks clean, and I visually inspected it, then I'll go ahead and put a new bandage underneath. And then some people like to change the trach ties before. It really doesn't matter what order you do it in. I put my gauze underneath just because for me that's what works, but you could actually right now change the trach ties if you wanted to, and then put your gauze. It's totally up to you. It really doesn't matter kind of either way. So I would place my gauze back in, slide it under, and then because I'm short, I go to the other side of the bed. I don't reach over my trach patients. I always just go to the other side of the bed, yeah, and tuck the other side. This can take a minute to get like good and fast at, because there's a dexterity to it that just comes with practice. Always make sure that your gauze is flat, that you don't have any creases, because if you're dealing with sensitive skin, it can cause like the lines that can then reach and cause other problems. So always try to make sure it's as flat as possible, and always try to make sure you get it under the phalange, because ultimately this is the point where you're gonna see the most potential breakdown, because patients move this way and it'll rub right here, and then it will also creates like a skin barrier to give a little cushion so it doesn't rub and create raw spots, red spots, and skin breakdown. Trach ties, I didn't bring any extra ones, but
There's some over there.
okay.
And a little bit to the far right.
Oh yeah. So as you're a new therapist, you may want a second set of hands when you do your trach ties. It's one of the things that can make people a little nervous, because at that point you have a released trach. Trach's free. So you can always ask nursing for assistance. They are happy to come in, oh, this one's better, and be your second set of hands. Okay. Again, if you have a large bed, or you have, you know, a lot of space, or you're short like me, sometimes getting to the other side of the trach without letting go of the trach is not an easy thing. So a second set of hands, particularly when you're starting out, nobody's gonna like be mad if you ask for a little bit of assistance, okay? So trach ties, so I always hold my trach here, but you wanna be careful not to put pressure. Like I don't wanna push in. So just kind of a hold on the trach, but not like a push. So this comes out. So technically now your trach is loose, right? So you've got to hold it and manage the Velcro. And the Velcro is very, very sticky, which you want it to be, right? But it can also be hard to get on and off. So you have 2 options here. You can attach your new trach tie to your old trach tie and pull this way, and you'll end up with both on the same side. Or you can scoot it under their head, however you like. So Velcro comes off, old trach tie comes out, new one's right here. And then again, sort of short, but the main point is I never let go of my trach. Always hold on to it. So this is loose for our mannequin guide. The general rule of thumb is 2 fingers. 2 fingers on each side is what you should have to make sure that it's secure, but not overly tight, not gonna create any pressure wounds. That pretty much, inner cannula, if you had it, now would be a good time to change it. This trach doesn't have an inner cannula, but that's pretty much it for trach care. Lots of cleanup. If you have a trach that has a lot of secretions, lots and lots, that's when you want your gauze, because you're gonna need the gauze to clean up the skin. The Q-tips just aren't gonna cover it. So I like to use 2x2s. They're the little squares, and I'll use still the same solution. Dip them in the solution, squeeze them out so that they're just damp and clean in the exact same way. Sometimes you'll need to go as far as here to kind of clean the chest if things have sort of spread outward. But that's pretty much it on trach care, except for suction. So you guys have your inline suctions. This is what we use. Inside this container is a suction. This is a 14 size catheter. Yeah. So this is what I use for most of my adults, unless they have a really small trach, and then you might have to do a 12. The other thing, who ended up with the, yeah. Can you borrow that? Okay, so this is a trach inline suction as well. You can use this hooked up to a vent, and you can use it hooked up to a cam. So the one thing I like to mention about these is that if you've got this hooked up to, so you guys have seen a cam, right?
Yeah, but that's.
Okay. So this hooks here, and usually you'd put like a little, there's a little thing, I call it an accordion. It's a space. It gives a little bit of give. It actually looks like an accordion. So you've got this hooked up here, and this is hooked up here, right? Okay, who sees a problem? Your patient's breathing in, right? They have to breathe out too. Where's it going? Yeah, it's going nowhere. Because I have not provided an exhalation port. So the one thing about these catheters is they've got this little gray piece. And I've seen this happen, which is why I bring it up. Somebody forgets to move the little gray piece. They've got no exhalation. All their CO2 is coming right back here. And what are they doing? Breathing it right back in, right? How's that going to create a problem for your patient? Big problems, right? Build up of CO2. Now we have a crappy ABG, and they end up on a vent.
They never should have.
And they never should have.
So you just put one little length.
Yep.
on the other
And
side.
this is actually in, it's not in this packaging, but it will, some of them actually come with this little piece.
Yeah, the dollars.
Yeah.
That's what the inline section is.
And if you don't have one, but you've got your blue tubing, you can literally make a cut and create your own.
They have little spot in between,
Yeah.
little 50 cc is what each one of those lengths is, and in between there's a spot right to cut.
Yeah. So always make sure you take off the gray piece. Now, if for some reason your patient has to go onto a vent or a BiPAP, gray piece just goes right back on, and you've closed your system. So suction from here, very easy. Feed this down. We go to, you're supposed to go to where you feel resistance, pull back slightly, and then suction, right? That's mostly what we do. If you hit resistance, just make sure you pull back. If you go down, your patient starts to cough, you haven't hit resistance, you really don't need to go down any further. They're gonna cough, suction it right out. Push here, suction connects here. If you need to use any saline to clear the suction, the little pink bullet connects here. Push the suction, push in the water, it'll clear the whole thing. So if it gets clogged or caught, you can clear it out. And that is pretty much that suction. This one, you have your sterile set of gloves. So I too glove it. These are dark purple. The ones we keep in the facility for regular use are light purple. I do clean hand, dirty hand. So clean hand gets my sterile glove. Have you guys talked about how to put these on?
No.
Okay. So they come folded up, right? You can touch anything with your dirty hand that's on the inside. So they do come folded up, which can make them difficult to get on. But you can use this extra hand to touch anything that's the inside of the glove. So see, my crease is the inside. You can see where the top of the glove is. So I can stick my hand on the inside to sort of work my way around and find the thumb, which is right there. And then you just kind of get the rest of your hands in. So I can touch the inside, not the outside. So now this is my clean hand. This is my dirty hand. My dirty hand gets the suction from the wall. My clean hand gets the suction catheter. We connect here, and then I can wrap this up and use it, okay? This would go in like this. Again, to the point where you hit resistance or your patient starts to cough. At that point, you would push down and suction out. And then kind of keep hold of it because you don't want it to flop around and hit things it's not supposed to. If your patient's awake, you can ask them if they feel like they need to be suctioned again. They will tell you yes or no. Yes, you go again. No, you're done. Suction goes back here.
Especially if this patient's
All
had
finished.
a trach a long time, they know.
Yeah.
They'll tell you, yep, please do it.
And patients who are awake and have had a trach a long time, you don't have to suction them every time.
No.
They'll tell you no thank you.
You have to suction again with that.
Mhm.
Do a different one.
Once I've let it go and I've put it back in and it's used, I get a clean one. This is like your trach patients are constantly back into the hospital for one reason. They're constantly getting infections. They get pneumonia, they get all of the things, and it's all different kinds, and it's because they're sitting here with an open airway and we're sticking things into it all the time. Now, we have to, right? We have to help clear secretions, we have to do all those things, but that's why your trach patients are coming back constantly.
They also come back if they don't have good secretion management,
Right.
which will lead to that too. Proper secretion management and cleaning techniques make a huge difference in
Yeah.
trach patients.
But anytime you put something in there, even with as sterile as you are, you're potentially introducing different bacteria. So that's why being careful with what you're touching and sterile and changing your gloves. And it's no skin off your employer's nose if you use 3 of these. It's better patient management, it's better infection management. So when in doubt, get a new one. She started out with a trach that was super tight, okay? Sutured in like nobody's business, like right up to the skin, no movement, no give, tight, okay? They removed her sutures after 3 days because the trach was so tight and they were concerned about skin damage, right? Generally speaking, sutures come out at day 7. So we're 4 days early. Sutures come out within 2 days. Her trach site is swollen, red, smells terrible, and is bleeding. This went on for weeks, regardless of antibiotics, of proper trach care, of head and neck consults, of wound care consults. This trach site, not getting any better. Stoma is large, looks overstretched, looks inflamed, this is not good, right? In the ICU for no other reason than this stoma site. So she goes like that a couple of weeks. I had her for 6 days in a row. On day 4, after we had wound consult and head and neck consult, trach just starts to bleed. like bleed profusely, bleeding. So our RT nurse, which is like your rapid response nurse, she's the one that comes to not codes, but codes. So rapid response is something that we call prior to a code. It's like a precursor. It's to get everybody in the same place to try and prevent a patient from stopping to breathe and having their heart stop, right? So it's like the beginning. Blood pressure problems, bleeding problems, all of those things would be a rapid response. So the rapid response nurse is walking by. I yap at her to come in and look. Trach is just gushing blood from the trach site to the belly, just blood everywhere, right? Changing out gauze, putting pressure, doing all the things. Doctors come in, head and neck comes in. We end up packing this patient with Surgiseal, which is it almost looks like chainmail. It's a gauze, but they use it to seal surgical sites. And so we pack the entire trach site with Surgiseal. We're holding pressure so that it stops bleeding in like this weird sort of claw way that the nurse practitioner had found. And it was and they ended up taking her to surgery because that trach site had eroded to the point where she had actually several blood vessels and veins in her neck that were just profusely bleeding. So it didn't actually say that in the notes because I did go back and look to see if that's what they found, but it just said several vessels involved, profuse bleeding, right? So they went in, they cauterized all these different vessels. All of that is the reason why trach care and stoma care and sites is so important. Now, in her case, I don't know what the original problem was. It could be that it was just sutured too tight and she had some bacteria or something under there that we just weren't getting out, which caused the infection, which caused the bleeding, which like sort of spiraled this. But that's why trach care is so important, and that's why stoma care is so important. So there's a difference between, so a stoma is for a trach. It's different than like a trachs and laryngectomy tubes. So laryngectomy tubes. I'm gonna draw my terrible picture again.
And then I'm gonna have to play a video.
Okay.
When you're done.
So your trach is your trach, right? But your laryngectomy tube looks similar to a trach in that it's got a circle there and it's got a spot for trach ties, right? And this is open. And then it sort of, and this is why I'm a terrible artist, comes off
Why we're not.
like that.
That's why we're a respiratory therapist and not artists.
Yeah. So a laryngectomy is an open hole in the neck that will never close. It's permanent. You've bypassed the upper airway completely. This is the only airway. That's important to know also with trach patients, because if you have an emergent situation, and I haven't ever seen this happen, but I've heard that it happens, they'll cover this and try to bag a patient through their upper airway. Now with a trach, you could conceivably do that. You could cover this and bag from here, right? But with a laryngectomy tube, you can't. There is no upper airway. You have to put the bag here and bag here.
Do you guys know why this is done? So patients who have throat cancer and vocal cord, they'll remove everything.
Yeah.
So there is no upper airway anymore. It's non-existent. So you can't, and you'll see these, they're more and more, our students are seeing them, and so it's important to understand that. And that's why I'm gonna show a video when she's done, but you can't bag up here. There's nothing there. So once that is in and they've had a total laryngectomy, they'll have this permanent stoma, that's their airway, and if they code or respiratory arrest, that's where you're gonna have to breathe for them.
Yep. And this sits flush, so it's not like your intercannular or your trach where you've got some place to connect a bag. This literally sits flat against the skin. There's no like connection piece. So usually, I've never actually seen it done, but I've been told you use like either a neonatal bag or a pediatric bag, depending on what you have on site. So that stoma always open, never gonna close. You could take out the laryngectomy tube and it would stay wide open. Your trach, obviously you have to be more careful, particularly if it's new, because it wants to close up. It's not a permanent, hopefully. And that's why you have to be quick. You have to position your neck correctly back if you're trying to change it out. The stoma is definitely something that you have to be watching for redness, and you can see it. If your patient's laying in bed and their trach is in, it's not going to be so tight that you can't visualize. You should be able to see it. And you just want to be mindful of it if you're changing out a trach, that you definitely are positioned in a position that will keep that nice and open. You can, in emergency situations, use the stoma as an airway without a trach. If they can't get a trach in, sometimes you'll see an ET tube go in instead.
Get a 6.0 and shove it in there.
Yep, and just make sure your pilot balloon is full if that happens. But there should always be trachs at bedside. If you have a size 6 trach in your patient, you should have a 6 at bedside and you should have a 5 at bedside. Something smaller in case you have an emergency. And I think that's it. Questions? Yeah.
How often should you be doing like trach care?
So we do trach care Q shift and as needed. We do 12s. So once a shift per RT and then as needed. I usually do full trach care first rounds, and then I'll change the gauze second rounds just for the benefit of my night shift partner.
How often do you change this trach collar?
Trach collars once a day,
Once a day?
done on day shift.
So it's not
Unless,
4 hours?
Unless
unless it gets saturated. No, it's definitely, the trach, this is not, did you say trach collar or
It's
trach ties?
collar.
Oh, trach collar. Trach collar I only change if it gets yucky. If they're not coughing up into it and they're just kind of hanging out, you could probably change it every 3 days if you want to, but likely it's just gonna get changed if it gets yucky.
If you see a patient like that woman,
Mm-hmm.
do you ever feel like, I mean, would you say anything? You kind of just have to deal with obviously what shows up, but do you have a concern about?
So our first resource is always, so what I did exactly was talk to my nurse. And I said, hey, this looks bad. And I've had her now for 4 days and it's not getting any better. Like, I'm not seeing any improvement. We're doing trach care on her every 4 hours. We were having to change the gauze, change the trach ties, change and do all of the cleaning along with her inner cannula every 4 hours. Typically done once every 12. So, and we were doing that round the clock. And she was awake, so she was clearly in pain. Every time you touched it, she cringed. And so I went to my nurse and said, hey, she needs another wound care consult. When was the last time wound care was here? She put in an order for a wound care consult. Next day I come in, still no better and still no plan. So wound care looked at it and said, yeah, it's infected. Great. So at that point it was like, okay, well, we need to call head and neck. Do we need to change the trach? Do we need to, like, what do we need to do? So head and neck came down, kind of did the same thing, but sort of put in a tentative plan on how to deal with it. And so we were doing that, but it really wasn't it was on my 6th day that they transferred her and then it just started to bleed everywhere. So at that point we were kind of
You initiated.
beyond. I did, but so did lots of people before me. Like, she had had several wound consults. She had had, the physician was asking every day in rounds, what's her trach site look like? So lots of people were watching it, but from what we do, I always just talk to my nurse, hey, when was the last time wound care came down for her? And she can look it up and tell you. So just communication is the key to that kind of situation. Nurse is always your first line, but if you're not getting any joy there, mention it in rounds. When you're rounding on your ICU patients, because that's your time to talk and say, this is what I need, this is what's going on, this is what I'm seeing. Because I can promise you, you're looking at that site way more than the nurses, even the ICU nurses. They're not looking at it near as much as you are. So you always, if you approach it collaboratively, when was the last time wound care was here? She's looking at the notes, she's already on the computer, she can see that clearly. I don't come at her like, hey, wound care hasn't been here in a week. Why is that? So.
So you mentioned about, like, for example, if the tray comes out and then it closes up. Have you ever had a time where you had to, like, open it up again? And, like, how did you
No.
Or do you know what to do if it does close up and you have to put another tray?
So if you're in an emergent situation, you're definitely going to be positioning your patient in a way that's going to keep that open, head back, towel underneath if necessary. But if the trach is out and it's a new, I'm usually just kind of holding the skin while somebody gets the new trach to pop in, right? Because you've got them at bedside, so it should only take a second to rip that open and get the new trach in.
Okay. So you don't have to, like, open it?
No.
Okay.
Never had to do that. I've only had trachs pop out every once in a while. Usually is when they're turning. So when nurses come in to turn your patient, depending on what they're hooked up on, if they're not mindful, it has been known to pop out. Usually it doesn't go anywhere. It's still connected to the trach ties, and they'll shove it back in and call you and be like, I just popped out this trach. Come and look.
Any trach that's been in longer than a couple weeks will go right back in unless something weird is happening with the patient. If they're really brand new, that's going to be bad. That's
Yeah.
why they tend to suture them in, and you have to be really careful about trach care in the first week after the trach's in.
With sutures, it's a little bit more complicated to do trach care because you can't get under there quite as well because it's usually sutured in pretty tight. They do usually suture here and here, and then the patients will come out from head and neck with gauze in between the sutures and the main part of the trach. We leave those for like the first 2 days, and then you have to pull them out because they are saturated and gross. And then the easiest thing to do is to actually cut your gauze to fit. So usually it's maybe from here and around, and then tweezers to sort of pull it up through. But you have to be really careful because every time you move that flange, you're pulling on those stitches.
And when it's brand new, it's very sore, of
Yeah.
course. So this is the innominate artery I was telling you about. It's the most serious life-threatening complication that can happen. It's not the most common life-threatening. The most common life-threatening is mucus plugs. Trachs get plugged all the time. But here is the innominate artery, and you can see if a trach is too close to it, it will actually rupture that. So when you see that profuse bleeding like that, it's usually because that's ruptured. There's a lot of other arteries over there as well, but the most common one that ruptures is the innominate. It's not very common. The claw that she was talking about is, I'll show you a picture. Oh, right here. Let me pull that one over. You would leave the ET tube in. So as crazy as it sounds, 2 things you can do if this happens. So if your trach just starts profusely bleeding like that, it's because something's ruptured. So you need to get it to stop as much as you can to stop the blood loss so your patient doesn't die. They got to get to surgery. So packing it, and then what you do is with the trach still in place, you put your finger in there, put your index in and your thumb on the outside, or you could even do this one too, and hold as tight as you possibly can to try to stop that bleeding. And you're not going to let go until they get them into OR. So that's what she was talking about, the claw. The other thing you can do is inflate the balloon with as much air as you can get in it to act like a compress on that artery as well. So that helps you understand what that's like, what the Larry tube is, because you'll see those, and occasionally an HME. So it's super important. Make sure they will tell you that the patient has a laryngectomy. And go ahead.
What is the Larry tube for again?
It's kind of like an inner cannula.
Yeah. It can help guide suction catheters.
Do you see it a lot or no?
So not every one of the facilities I worked at has done the procedure. So South Sacramento Kaiser does this procedure, and so we have them quite a bit there. But in my regular practice out in Roseville, not really.
UCSF, Stanford, any place that does those. And the Larry tubes are very common.
Yeah.
So most patients actually keep them in. And then these are the patients that would speak with the voice box. That's the only way they could potentially talk, a couple different ways. But That's a patient you know has a total laryngectomy. And I think, don't they usually put a sign above the bed? Yeah, that says
Yeah, and
that.
you'll see a sign above the bed with your trach patients too. It will tell you what trach size, particularly in pediatrics and in NICU, how much fluid is in the cuff, that kind of stuff.
Other questions?
One of the things that's super important that we're finding students can't do when they get to clinic is set this thing up. This is a suction canister and the stuff that you need. Not every place has them in a nice little bag like this. Matt was telling me at his hospital you have to gather everything separately. This would be in the wall. We don't have piped in suction, so we just fake it. But we do have suction machines, which we'll get out after the break. Because you guys are gonna, so the suction canister, so what you need to set up suction is a suction canister, a short tube, this one's really short, they're not all that short, and then a 6-foot tubing. And then a lot of times there's a little filter as well that will make sure to keep any secretions from going back into the gauge. So on the top here, it's gonna tell you to suction to patient. Some of them say tandem and then to patient. If it's tandem, it means it's going back to the gauge, the suction source. So these aren't hard to set up, but people fumble. And patients with trachs, laryngectomies, and when you're called to a code, the first thing you need to do is set up suction and get your ambu bag. So, because once you're ready to intubate, once you have a ET tube in your hand, the doctor wants to intubate, and you go to give him the tube, and then he says, okay, I need suction, and you didn't set it up. So, first things you do. So you guys have to know, and with your preceptors, you should need to know how to do this. So, because it's not gonna automatically be in every room. Suction's there, but we're not opening these up and setting them up unless we need them. So you gotta make sure you get the lid on tight. You could see that how I had it at first. Might have looked like it was on, but it's not. You're not gonna get any suction. So you gotta put this all the way down, snap it into place. The long tubing is gonna go to patient. Oh, that just fell out, we'll fix that. And then to our suction source. And then this tubing, whatever it might be, short, is gonna go from here to here. So it's kind of like we were saying with the humidifier, from the machine to the water, from the water to the patient, from the source to the canister, from the canister to the patient. And that's it. And then you just have to make sure the suction's set up. And then you can connect this to the suction device, to the Yonko, or to whatever it is that you need. So we're gonna be practicing with this today too.